Okay. So today we have with us Dr. Mypinder Sekhon, who is an intensive care physician and clinician scientist at Vancouver General Hospital. He was recently funded by TRF for his TRF CDTRP venture grant entitled Characterizing the cerebrovascular physiology of circulatory death during withdrawal of life-sustaining therapies in humans. Now, I know that that's a mouthful, but fortunately, Dr. Sekhon is with us to help shed more insight into what that all means and what his research is about. But before we get into that, I'd like to first ask you, Dr. Sekhon, if you can tell us a little bit more about yourself, as well as what your connection is to the world of organ donation and transplantation.
Yeah, for sure. So first off, thank you very much for the invite, Christy. I feel very privileged and fortunate to be involved, to be supported by CDTRP, and to be undertaking this project. Our family's connection to transplant is one in which none of my family members have undergone transplantation, but one was listed, or pardon me, not even listed, was being considered years ago, many years ago, and he didn't make it at that time due to the scarcity of available grafts, essentially, and donation opportunities and transplant opportunities. And so in full disclosure, I never embarked upon medicine as a career nor research directly with aiming to get involved into transplant, but have that lived experience of seeing someone who could have been considered had there been more opportunities. When I entered medicine and I entered critical care medicine, I got very interested in how the brain works and the physiology of the brain, and my PhD focused on how the brain's blood vessels react and how the brain handles oxygen after undergoing an injury. And that was our research program on how to improve outcomes in patients with acute brain injury. Of course, many patients in critical care who undergo brain injury are not able to survive and have full recoveries, and so as such, we transition to palliative measures. This project was actually stemmed from a patient and a patient's family. A younger gentleman in his 20s who had a post-cardiac arrest, was not neurologically brain dead, underwent withdrawal of life-sustaining therapies, and then timed out for DCD. And timed out in the sense where the blood pressure was, 40 on 30 for quite a while, but no signs of life. And so I had the question, and so the family was obviously devastated. I still keep in contact with his parents. In fact, I went to his memorial service. And they were absolutely devastated that he could not provide the gift of life. And a central question in my mind in this gentleman's case was in fact the patient lacking brain function and blood flow, even while the heart was beating at a very low function. And so that's how we kind of decided to embark upon this project. It stemmed from a case, actually. And then, of course, our family's lived experience provided a bit of inspiration as well in terms of wanting to pursue this angle of research more.
Thank you. Thank you so much, Dr. Sekhon, for sharing that, for sharing your own personal story, but also how this project originated really from those patient-identified priorities and those caregiver priorities, which I think we can all appreciate is so important. But I noticed there you mentioned DCD, which of course is what your project is about. It's about donation after circulatory death and expanding what is known around that. So if you can actually break that down a little bit for our viewers and tell them what is meant by donation after circulatory death, also known as DCD.
Yeah, such a good question. So the one largely needs to have passed or to have died before being an organ donor. And so the definition of death is obviously moved towards a brain-based definition of death. So the permanent loss of brain function and blood flow, thereby the moment at which that happens, and the irreversible loss of it being the definition of death. The guidelines were recently rewritten this year. And so how one donates is obviously, if there's a catastrophic, there's two ways after death. If there's a catastrophic pathology that occurs within the cranium or the cranial vault that results in absence of brain blood flow and then brain function with the heart beating, that can be neurological brain death. Or what we can do in patients who are not neurologically brain dead, so still have some rudimentary brain function, but where the prognosis is really dismal, is we provide them with palliative care as we normally would for any patient. As the heart function starts to decrease during that removing of the breathing machine and so forth, once it decreases to a level where it is unlikely that the brain is receiving blood flow, so therefore oxygen, and then not functioning, we can declare death. The pragmatic definition of that is when a variable called the pulse pressure, or the difference between the systolic blood pressure when the heart contracts versus the pressure when the heart relaxes, the diastolic blood pressure, when that's less than 5, we deduce that the brain is lacking blood flow, oxygen, and then function. And so that meets the clinical requirement as to when the patient can be considered for organ donation or the time of death. Now, the longer that period is, the longer that process takes, the longer that the eligible organs, whether it be the lungs, the liver, especially the kidneys, can deteriorate in their function. And so the concept of DCD, or donation after cardiac death, organ donation rates have skyrocketed because of that, which is fantastic. But the longer the duration between the withdrawal of life-sustaining measures, i.e. the ventilator, and then meeting the clinical definition where the pulse pressure is less than 5, the longer the duration of that there is, the less donation opportunities there are. Because, for example, in the setting of liver transplant, most programs will say if that period is longer than 30 minutes, they will not consider the liver anymore. Secondarily, also, the longer the period that is, the worse that the recipient organ function is. And so, we wonder, are we waiting excessively long? Could the brain actually be lacking blood flow and oxygen and function before we have to wait till a very end stage event like a pulse pressure of 5 or less? So that's what this project sort of gets to.
Wow, no, that's fascinating. And I'm hearing a lot of reasons, not only for the donation side, but also for the recipients, why this research is so important and why it matters. So thank you. Thank you for explaining that in more simplified terms. I think we can all appreciate that. So I am curious as well, how you see this research advancing the field of what is known in organ donation and transplantation.
Yeah, absolutely. So this is really a pilot study, and how we're proposing on studying this is a very different manner than has ever been done, and I don't think it's ever actually, I know it's not been done in medicine before. One of the unique things about Vancouver General Hospital is we have a fairly robust what we call neuro monitoring program, so monitoring the brain. And how we do that is with a series of microcatheters that are for clinical care that are placed directly within the brain. And a few of those microcatheters, they're less than a millimeter in diameter. They read in real time, second by second, the amount of oxygen in the brain, also the amount of blood flow in the brain. So because we place these as part of clinical care, what we have done in a few patients so far is gotten consent from the families after prognostication, and it seems like it's going to be a dismal prognosis, and the catheters were placed as part of clinical care. We get consent from the families to just leave the catheters in situ during the withdrawal of life-sustaining therapies process, to see what is the precise moment at which the brain lacks oxygen and lacks blood flow, and then compare that against what the blood pressure of the patient is and heart function. So that's how we're proposing to study this initial cohort of patients, to provide some preliminary data, but some really high granularity and really valuable data, because these are actually gold standard catheters sitting directly within the brain parenchyma, to provide us with data to springboard future studies that can evaluate this in a non-invasive manner.
Wonderful. Thank you. Yeah, that is so exciting, because I think that really it serves as a springboard for really helping to potentially transform what we do currently know about donation after circulatory death. So obviously having wide-ranging impacts for our patients. So thank you. So final quick question I'd like to ask and put forward to you is, I know that you have two patient partners. So those are individuals who possess that lived or living experience that is the focus of the research, and they are part of your team. So I'd love to hear from your perspective on what you envision these individuals having their role in this research, and also what value you see that they will be adding to the team and to the research project as a whole.
Yeah, thank you so much for that question. One of the patient partners, the parents, are actually the parents of the case that inspired this research program in the first place. So a few things. One, both of these patient partners provide us with, they played integral roles in the development of this pilot study, and continue to be part of our steering committee, where I meet with them regularly to update them on the progress and future plans. They have informed part of the consent process in terms of how to approach families in a patient-centered way, especially during a very tough time in the patient's and families' part of their life. So that advice has been absolutely invaluable. So they're also involved in creating a study pamphlet for patients and families that, or for families that we can distribute to provide information about the study, the rationale, the data collection, how it will be used, but to provide that in a lay language, family-centered manner. I don't view this relationship with these patient partners to end after the study, but instead to grow and flourish, and hopefully with more patient partners as time goes on, and as we start to develop this research program into other research questions, and look to see if there would be a way to personalize the donation process instead of our current pragmatic but yet one-size-fits-all donation approach.
Excellent. Exactly. They have such invaluable insight and perspective to the overall process, and of course can continue to aid you even in that dissemination and that socialization of the work. So thank you. An absolute final question. Can you tell us a fun fact, or perhaps even a boring fact? Because sometimes the fun piece is a bit too much pressure. So how about a fact about yourself that others may not widely know?
Yeah, for sure. Fun fact about myself. Well, I mean, there's a lot, I think. But I love water parks.
Oh,
Um,
that's
uh,
awesome.
and in fact, my wife and I have in the past organized trips down the western coast of the U.S. centered around the American water parks. So like water slides, it is just like the best place in the world. Um, gosh, what was the other question? There was a fun fact and there was something
Well, I
else.
said, or a boring fact if you felt too much pressure by the fun fact, but I really liking the fun fact. That's a fascinating fact. So,
I've got more too.
okay, give me another one. This is
Okay.
good. This is good stuff.
Yeah. Well, and I've got tons of time. You don't have to stop the interview right now. So another fun fact. We have a 1-year-old daughter. She's 14 months. She doesn't sleep. But which is not unexpected, I guess. We had organized a camping trip. We're tent campers. And we planned to go for 7 nights, but we came back after 2. We realized it's very hard to camp with a 1-year-old in a tent in
Yes,
BC with fires and when it's hot. So
I
I think
agree.
our camping dreams are gonna have to get put on hold
They
for
might
a
need
few
to go
years.
on the back burner just for a few years, or maybe a trailer or something. I don't know.
Yeah, yeah, we don't have the room to store a trailer anywhere, but yeah, perhaps we'll have to rent one or something like that.
Exactly.
Um, yeah.
No, that's great. Thank you. Thank you so much, Dr. Sagan, for taking this time to chat with me. Again, I know TRF, we are delighted to be able to fund this very important and vital research. So thank you. Thank you for that. And I know we'll be coming back to you for an update at some point. So
Very much appreciated. We'd be absolutely thrilled to provide an update for you. And I just wanted to say again, very much appreciate the opportunity for this. And yeah, hopefully we'll continue to grow this. I'm very confident we will. And look towards informing the donation processes to really provide high quality grafts and a number of grafts to people who really need them.
wonderful. Thank you.